to the Heads Up series. This presentation is all about surgery. My name is Eleanor Van der Zanden. I have just got into core surgical training starting in August 2023. I'm currently a clinical fellow at University Hospital Sussex, and I'm really pleased that I'm staying in the area around Brighton for my core surgical training this August. This presentation aims to take you through applying for core surgical training, which can be really daunting, and also some tips and tricks I wish I had known before I applied. So to begin with, we'll go through some of the pros and cons of surgery. Starting with the positives is its high intensity, high acuity, managing acutely unwell patients and often going to emergency surgery, which can be really exciting. You're working in a team environment inside and outside of theatres, often doing rounds with the consultant and the registrar, and obviously within theatres you'll often have a really good theatre team. There are plenty of opportunities for research and teaching within surgery. The training programme really encourages research and publications, as well as getting involved in teaching wherever possible. And if you would like to, you can do one of the academic clinical fellowships in surgery. There are loads of surgical specialties to choose from, and within these you can further specialise in, for example, robotics or surgical oncology. It's probably the most practical specialty, developing your practical skills again inside and outside of the operating theatre. And as I said before, there's a range of surgical specialties that you can choose from. With any field of medicine, there are obviously going to be some cons. Mainly is the competitive nature of surgery. Unfortunately, this spans throughout the entire of your training, all the way up to consultancy and beyond. It's not just core surgical training that's competitive. It's very on-call heavy, and we will be doing nights until we retire, unfortunately. But this is where some of the excitement and the managing acutely unwell patients comes in. There are lots of exams and mandatory courses within surgical training, and these are unfortunately again self-funded, which makes it a very expensive specialty to train in. Core surgical training is just the start of a very long training process. So you do 2 years in core surgical training, and then it's 6+ years before you become a consultant. And surgery is a very intense specialty, which unfortunately comes with high stress situations and high burnout rates. Fortunately, this is getting slightly better with access to wellbeing services and the introduction of less than full-time training in most specialties. This is an image sort of overview of the training programs and the ways that you can progress through training to become a consultant. I'll firstly go along the green path, which is the most well-trodden path towards becoming a consultant, which is where you will complete F1 and F2, which takes 2 years. And during your F2 year or an F3 year, if you choose to take one, you apply for core surgical training, which again is a 2-year programme of CT1 and CT2. Within this, you rotate around surgical specialties, and throughout your CT2 year, you're thinking about your higher specialty training and applying for what we call ST3 and beyond. This is where you pick one of the specialities that you want to train in and hopefully get a place from ST3 to train all the way up to ST7 and sometimes 8 before you become a consultant. This talk will focus on this route mainly, but I'll tell you about 2 other ways that you can become a consultant as well. So up the top there in orange is what we call a run-through training program. So this is basically where you get into your ST1 and your training goes all the way through until ST8. You don't need to do core surgical training and reapply. And you apply for these in the same way that you apply for core surgical training, which I'll talk about next. Unfortunately, these training programs are few and far between, with only a few specialities available, and they're often only available in certain locations. For example, this year, there were a few general surgery themed run-through training programs, but only in Scotland and Wales, and there are a couple of ENT in the northeast, but this changes each year, so keep an eye out. And lastly, at the bottom there is CREST and CSER. So CREST stands for Certificate of Readiness to Enter Specialty Training. It's basically a massive long form in which you complete and get signed by a consultant and your supervisor to say that you have the skills and competencies that equate to a core surgical trainee, and therefore you are at the same level and ready to enter and eligible for ST3 training and beyond. So say you do an F3 year, an F4 year, an F5 year, you've either decided not to go for core surgical training, or you weren't sure about surgery at the start, or you didn't get into core surgical training. You can therefore do clinical fellow years for as long as you like, and then get the CREST form signed off by a consultant, which basically says that you are able and eligible to apply for ST3. This is obviously very appealing because you can live where you want to live, you're not governed by a national training programme, but I would highly recommend you going and reading the CREST form requirements because it's a really, really long process. You've got to ensure that you've got a consultant and a supervisor that is happy to sign off all of those competencies, and it can be quite labour intensive as well. So after CREST, you can then go into the green ST3 and beyond in higher specialty training, or if you quite like sort of doing your own thing and continuing doing clinical fellow years to senior clinical fellow years, you can do what is called the CSER route, which you might have heard of. This is the Certificate of Eligibility for Specialist Registration, which again, when you become a higher specialty registrar in your clinical fellow years, you can get another really, really long form signed off by your supervisor and your consultant that says that you are basically at a consultant level, that you have all the competencies, that you have all the skills, and therefore you can apply to be a consultant. As I said previously, this talk will mainly focus on the core surgical national training route and getting into ST3 and beyond. So after you've completed your 2 years as a core surgical trainee, there are a wide range of surgical specialties to choose from. As you can see, everything from cardiothoracics to ENT to urology to paediatric surgery. I would highly recommend thinking about where you would want to end up even before you've done core surgical training, what specialties interest you, and looking at the ST3 specifications before you apply for core surgical training. Most specialties would like you to have a certain number of years or months in that specialty before you apply for ST3, and this is important when considering your core surgical training jobs to make sure that you've got enough experience in the relevant areas. Some specialities also don't want too much experience, so I think it's really important just to have a read of those, and it can also help narrow down things that you need to do to gain points, for example, publications or presenting at conferences. It helps hone in your CV and gives you a bit of direction. So this is a brief overview of the application process, and I'll go more into detail about individual things on the next slide. But everything kicks off in November with Oriel opening. You then get your login details and you create a profile, and you can apply for multiple specialties on Oriel. By mid-December for core surgery, you need to have uploaded your self-assessment, which is pretty self-explanatory. It's just allocating yourself the number of points you have in the relevant areas, which I will go through later. You'll then be invited to complete the MSRA exam, which was introduced this year, slightly controversially. And there is a 2-week period in January in which you take this, and it's in one of those computer centres like you do your driving theory test, and usually lasts a couple of hours. We then get to February, where you need to upload the evidence for the self-assessment that you did back in December. And I'll go through that in a bit more detail because it can be quite complicated. And then between February and March, they send out invites for interview. And then all the way in April, it feels like forever, finally offers come out, and then the offer acceptance program starts. So to go through a few of these in more detail, starting with the self-assessment. If you get an interview and you get to the end, this comprises 30% of your total score, and I'll go through the individual sections in a second. It's really important when you do this self-assessment that you don't over-assess and that you don't say things that you haven't got, for example, because they really, really do look at it, and the evidence they need is really, really specific. So it's important that you're really honest and that you don't put things that you haven't completed before the deadline of that day. So say the self-assessment deadline is the 10th of December. Everything that you put on there must be completed by the 10th of December. If you're going to a conference the week after, that doesn't count. So everything must have been done prior to the date that you click send on that self-assessment. So as I said, the MSRA was introduced this year, and I'll talk about that a bit later in the talk. Basically, the top 1,200 applicants from the MSRA will be invited to interview, and at the end, this comprises 10% of your total score. Moving on to February, this is where you upload all the evidence for your self-assessment. This can be a very stressful process of uploading it all because they have really, really strict guidance. And I would highly recommend you start thinking about all the evidence that you need and collating that from back in December when you put in the self-assessment. Then we move on to the interview. So as I said before, the top 1,200 people from the MSRA will be invited to interview. And of those 1,200, you're competing for about 550 to 600 jobs. And your interview score comprises of 60% of your total global score. As you can see at the bottom, the competition ratio is about 3.7. This is 2021 to 2022 data, so soon the 2023 data will come out. The competition ratio does fluctuate from year to year, but surgery usually is one of the most competitive specialities, unfortunately. So I'm going to go through the self-assessment sections in a bit more detail now. And again, give you tips and tricks that should hopefully make your application a lot smoother than mine was. So first of all is operative experience. This is verified by using the e-logbook, which is an online logbook system, which is free to sign up, and you should sign up now just to have a look and see how the information is put in. When you come to applying, you can create what's called a consolidation report, which is basically just a printout which summarizes all of your operative experience, and that needs to be signed, dated, and GMC numbered by your consultant. To count as operative experience, you must have at least been assisting. Observing, unfortunately, doesn't count. So assisting or doing the operation and having your consultant scrubbed in counts as operative experience. Even if you're scrubbed in with your consultant and your registrar and it's you and you're hardly assisting, but you're in there and you have assisted in the operation in some way, this counts as assisting. It's really important that you keep a log of these, trying to get into theatre as much as possible, because up to 8 points can be awarded in this area. Moving on to conferences, so you need to have attended 3 surgically themed conferences by the time you upload the self-assessment for 3 points, which is the highest you can be awarded. As evidence, you need the certificates from these conferences, and they're quite specific about what the certificate has to say, so it must have the awarding body, any evidence of CPD, obviously with your name and the date, etc. Conferences can be quite expensive, so I would recommend start looking now. There's a few free conferences and online conferences you can go to, especially if you're an F1 or F2 or if you're a medical student. They can be discounted, so start having a look now and planning in advance. So next is surgical experience. This is different from your operative record. This is your experience in a surgical specialty. So most people shouldn't have an issue getting maximum points on this, because most foundation year programs, you must have one of your placements as a surgical placement. An elective in surgery also gets you 3 maximum points. If for whatever reason you haven't done an elective in surgery, or you have a surgical placement in your F1 or F2, you can do surgical taste a week, which can be 5 days of surgery. And this doesn't have to be 5 days in a row. You can do a day in different surgeries over a number of months. Again, as evidence, you just need a signed form that explains your surgical placement, the hospital, the dates, a supervisor, or if you've done an elective, the same sort of thing, where the placement was, the hospital, the dates, and somebody has signed it with their GMC or their registration number underneath. So moving on to quality improvement and audit. This is the bane of most of our lives, and we're constantly required to do audits and QIP programs. And as part of foundation year, you need to do it for your ARCP. So this is a really good place where you can kill 2 birds with 1 stone, as it's compulsory for your ARCP to start getting points for your core surgery application. As you can see at the top, for 8 maximum points, you need to have been involved as the leader in all aspects of a surgically themed QI or audit project that has demonstrated change. And it must have completed 2 cycles. Underneath that is the same, but it's if you've led in all aspects of any QI project that hasn't been surgically themed, and again, you must have completed 2 cycles. 4 points is that you've been involved as a contributor, so you've collected the data or you've helped present the data, but again, you must have participated in multiple cycles. And at the bottom is that you're involved in some way in an audit or a QI project. Now, this can seem really daunting that it says you must have led in all aspects of a surgically themed or a non-surgically themed audit, but honestly, it's much easier to be done than you think. Basically, any audit or QI project that you've done, that you've only completed 1 cycle, go back right now, collect some data, and do a local presentation as soon as possible, just so that you can get the minimum points at the moment. I had done a QI project in the A&E department when I started applying, but I'd only done 1 cycle. So I just went back, collected some raw data, not very much to be honest, and then did a local presentation in one of their clinical governance meetings just to have something to fall back on. However, if you've got time or you're just starting your F1, or even if you're starting your F2 or halfway through, there's always time to start a quick QI project and do 2 cycles by the time that you apply for core surgery training. At the bottom there, you can see there are some bonus points, if you like, for presenting this QI project at different levels. So 1 is a local meeting. So like I said before, just get your audit into a clinical governance meeting or an M&M meeting as soon as possible, just to have 1 point to fall back on. 3 is for a regional meeting, and 5 is for a national or an international conference. Again, any QI project or audit that you've done recently, that you have some data in, that you have a presentation for, or that you can write a nice abstract, just start entering it to any national conferences that you can find. Even if you're a medical student, there are loads and loads of medical student related QI and audit project conferences, and this is a great place to start and gets you 5 points. Just a note on the presentation, you must have been the first author and it must have been presented by you, and you need an evidence of the slides when you upload all your evidence. You also must have a letter from the supervising consultant with the name, date, GMC, etc. And for a presentation, you need to have like an acceptance letter that says that you've been accepted to present this at whatever conference or local meeting. So there were lots of changes this year for the self-assessment, and this was another area that things drastically changed in the presentation and publication section. So it used to be that you could only get maximum points as a first author of a PubMed publication. Now at the top, if you have won a prize for an oral presentation at a national or an international conference, you get 10 points. I would say this is much easier to do than getting first author on a PubMed article. And this doesn't mean to say stop doing all your articles and your publications. Definitely keep going with those because they get you points later down the line and they're great for your CV. But if you are in a rush or you're feeling overwhelmed by the idea of getting a publication, like I said before, start entering all of your abstracts into national or international conferences. And also when you do it, make sure that you've entered for an oral presentation as well as a poster presentation. If you're then accepted to do an oral presentation, you can win a prize and then get maximum points on your core surgery application. Below that at 8 points is that you've done the presentation but you haven't won a prize. At 6 is the first author of a prize-winning poster or an oral presentation, again at a national or international conference. And down at 4 is first author of 2 or more posters or presentations, first author of a case report or a book chapter relating to medicine. We continue going down to 3 points for prizes and publications. So this is that you have collaborated as part of research in 3 or more PubMed cited publications. 2 is that you're a co-author or that you've presented at a regional medical meeting. And at the bottom is that you're a first author of 1 poster at a regional meeting, or that you've collaborated in 2 PubMed cited articles. Now, if I just go back to maximum points, I would argue that it's a hell of a lot easier to get a prize or even do an oral presentation at a national conference than get multiple PubMed cited articles. So I would definitely aim for both of these, and this is where I got maximum points for an oral presentation and winning a prize. So next is teaching. Most people, either as a medical student, F1 or F2, have had some involvement with teaching, and lots of people really enjoy it. So this should be an easy way of getting lots of points. So at 10 is that you have designed and organised a teaching programme, which are 4 or more sessions at a regional level. Below that, at 6 points, is similar, but that you've done this at a local level. And down at 2 points is that you've provided regular teaching for healthcare professionals or medical students. So most people listening now, you could definitely get at least 2 points. I'm sure you've all done teaching sessions for medical students in lower years as part of societies, or revision lectures maybe for final year medical students as a foundation year 1 or 2. It sounds potentially quite daunting to say that you've designed and organised a teaching programme, but it's a lot easier than you think. For example, if you are on trauma and orthopaedics at the moment, you could set up a weekly X-ray teaching session for your friends or for the nurses or HCAs on the ward. You just need to do 4 sessions, which is a weekly session for 1 month, and then get your consultant to sign off that you've designed and organised a teaching programme at a local level. Or whatever speciality you're on at the moment, you could do weekly teaching sessions for nurses or HCAs on common side effects of drugs, recap on basic skills such as cannulation or ABG interpretation. Or if you're on GP, do 4 sessions on looking at rashes or some dermatology teaching. After these 4 sessions, you just need to get some feedback from the people that you've taught, which you can easily do via an online or a little paper feedback form, and that you just need a letter from your consultant saying that you've designed and organised these sessions, that you've had some feedback and you've reviewed it with the consultant, and they just need to sign, date and GMC it. And that would really easily get you 6 points. Obviously, it's even better if you could take that one step forward and do that at a regional level, so you could do the same in multiple hospitals. And I would again recommend reading the specific guidance for the self-assessment at what classes a regional level. So next is qualifications. At the top is that you have a master's in education or specific postgraduate qualification in teaching. So at the top is 4 points for a master's. Next is 3 points for a teaching specific PG cert. And at the bottom is training in teaching methods lasting at least 2 days. So if you are currently a medical student thinking about intercalating, even though it might not be your specialist interest, I would highly recommend thinking about a master's in medical education for your intercalated year. I know you don't get points for it for F1 and F2, but you do get points for any educational training further on. For example, here in core surgical training and even all the way up until consultancy. So it's a really easy way for a year to get these points in your applications forevermore. If you are considering doing an F3 or you're an F2 at the moment and you somehow have loads of time, then you can consider doing a part-time master's if you think you have the time and the brain space for it. Next down at 3 is the PG cert. So this is what I did. If you do an academic foundation program that I think is now called SFP, some trusts will pay for you to do a PG cert over your F1 and F2 years, which I was very lucky to get. As a clinical fellow in some trusts as well, you can also get a PG cert funded in medical education if you're a teaching fellow. Obviously, a PG cert and a master's is something that you can self-fund as well, but obviously this is probably the more expensive option. And when they say at the bottom, teaching methods lasting at least 2 days training, there is a course called Teach the Trainer, which is much cheaper than a master's or a PG cert, and you can even do it online. So again, I'd highly recommend doing this. I think it's a couple of £100, and again, you get points for any teaching training that you've had, not just in core surgical training, but ST3 and beyond. So I hope I didn't go through any of that too quickly, and you can always rewind and listen to the bits again just about the self-assessment. The thing that I would really stress is that you just Google core surgical training self-assessment 2022 to 2023 and have a look at the specifics and exactly what evidence every section needs. It's really important that you start collating all this information early because you won't be able to do it in the 1 week that the self-assessment thing uploads. And often you need consultants to sign things and you could be waiting a really long time for them to answer their emails. So stay on top of it, be really organized. And I actually did a spreadsheet of everything that I needed to get signed off and then went into the hospital one day, printed every form and every letter I needed the consultant to sign off, and just found every consultant in clinic and made sure that I had all the information, all the evidence that I needed. As it is the MSRA score that actually decides whether you get an interview or not, it's important that you get a high score in your portfolio, but it won't alter whether you get an interview or not. So a really good score is probably about 42 in the portfolio out of 52, but there are people who have much lower scores in the portfolio that absolutely smash the MSRA. That means that it sort of levels out. So it's important to get a good score, but remember there are other places that you can get points as well. So this is just a brief slide about the MRCS exam that you need to do by the time you apply for ST3. So it should be done by your CT2 year, really. You used to get points for this, have done it before you apply for core surgical training. You no longer get points for this, just like you no longer get points for courses. And the idea of this is that it became sort of a pay-to-play system in which people that could afford to do courses and the MRCS before they applied were getting higher scores than those that couldn't. I personally think it's a good thing that they've taken out sort of the monetary aspect of applying for core surgery. But again, you can start thinking about doing your MRCS in your F2 year or an F3 year if you're deciding to take one. There are two parts of it, the written, which is part A, and the OSCE style, which is part B. These are very expensive exams, and unfortunately most people have to retake at least one of them, so that's something to consider as well. So moving on to the MSRA. Sorry for all the acronyms, it can get quite confusing. This is the Multi-Specialty Recruitment Assessment Exam. It's been used in multiple specialities in the past and was originally created for the general practice applications. Rather abruptly, before the applications opened this year, core surgical training applications announced that the MSRA would now be part of their recruitment system. The exam is used by multiple specialties, so if you're thinking about applying for anything else, you're likely to have done the MSRA anyway. So it's not really going too much out of your way to have to do it for surgery. Lots of people who apply to surgery also apply to radiology or anesthetics, for example, and your score will count towards both of these applications as well. I will go through the types of questions and the two parts of it in a second, but just some advice that I got some online questions about 6 weeks before the exam. There are multiple online question banks that you can try. There's PassMed, eMedica, and also PassTest. I'd recommend just getting any and all of them. I've heard different things about different ones. I personally use PassMed, but I've heard eMedica is really like the online interface, so that's good practice as well. I did some basic revision, again, of the topics that come up, which are mainly GP-related topics, things like asthma, the CAPD ladder, contraception, etc. I then just did question after question after question, and anything I was struggling with, like drugs for hypertension, I would then do a bit more studying about that and then come back to the questions afterwards. I think I completed the question bank like 3 times, so it's definitely just focus on questions, questions, questions. Health Education England recruitment actually give you some example papers for the MSRA, and I left these about 2 to 3 weeks until my MSRA exam date and treated them like a mock exam, and then at least I had some time to focus on anything else that I was struggling with until then. The exam is an online exam, so it's actually a really good idea to use some of the online question banks to get used to doing the exam online and clicking through things. You get the link to book the MSRA via Oriel, which is where you'll get all of your information about your applications. You then book it in like a local test centre, And I would highly recommend thinking about whether you're a morning or an afternoon person, because it is a couple of hours, the whole exam. So think about whether you'd rather be doing that in the morning or the afternoon. Also, if you get extra time for any learning disabilities or you have any special requirements that you will need during the exam, on your oral application back in November when you start, there is a little section that says, do you need any special requirements for any upcoming exams or interviews? And this is where you submit your evidence. It's really hard to do it in retrospect. So I'd highly recommend getting all your reports together for any requirements that you might need and uploading it right at the beginning, so that if you need extra time in your MSRA, you'll get this, or if you need a notepad in your interviews, for example, this can all be processed in time. There is no official sort of cutoff for the MSRA score because it's all standardized around like standard deviations and things. So when I trawled online and multiple different forums to see around what MSRA score got selected this year, it was about 540. So you should be aiming on your MSRA score in any mocks that you do for getting around probably 70%, I would say. You can read a bit more about how the MSRA is tested and how they do the calculations about where you sit in the bandings online. So the first half of the MSRA is the professional dilemmas. This is SJT style questions and you get 50 scenarios. Here is an example that you can go through in your own time. And most of you, if you've just done the applications for F1 and F2, you might be used to this after doing your SJT for that. The classic advice is do what you should do, not what you would do. And I would read GMC's Tomorrow's Doctors and all those things about ethical guidance online, just to remind yourself what to do in certain situations. All I would say is that patient safety is number one, and always make sure that you're going to the person first about any concern. So if you're concerned about a colleague, always go to them first and then go up to their supervisor, etc. After the professional dilemmas, you've then got the second half of the exam, which is the clinical problem solving. This is 97 questions on clinical cases which have a primary care focus. Again, this is an example question that you can go through in your own time. I would again recommend going through the online question banks because you can see common themes coming up, things like hypertension related questions, but then with specifics about Q risk scores and what medications you give to different patients. Lots of diabetes with specific HbA1cs for different drugs, all about contraception and the revision of the new asthma guidelines and things for COPD. Hopefully, with a bit of practice and revision, all of these topics and the information will come flooding back to you, especially if you've recently done any other exams. So now on to the interview. The interview is in two different sections, the clinical station and the portfolio and management station. The interview is all done online as it was this year. That might change, but I think they quite like the online format, and it means people don't have to pay and travel to come down to interview centres. There are lots of courses online about interview technique and practicing interviews, and there's varying information about how long you should practice for. To be really honest, I started prepping maybe 2 months before my exam or my interview. I started reading online about how much preparation I should do, and I read that people had been practicing for 2 years or prepping for 6 months, and that really freaked me out. But honestly, if you hone in your skills and practice with friends or registrars, then I think that doing your own preparation a couple of months before is more than enough. I didn't go on any interview courses, so I can't vouch for how good they are, but I have friends that went on them and found them really helpful and gave them sort of points of things to revise and also gave them feedback on their interview technique. There are 2 books that I would really recommend you getting. The first one is the Core Surgical Interview Green Book by Alexander Logan and Andrew Fisher. This is quite an old book and it is based on the old sort of in-person interviews, but the sort of format of the clinical stations is still the same, and lots of the same questions in the portfolio and management stations still come up. It also goes through the presentation that you have to do, and that's really helpful to have a bit more information about that. Also the blue book, which is Medical Interviews book by Oliver Pickard, which is more general about all medical interviews. So it's also helpful to read if you're applying to any other specialties. And this kind of gives example answers in good and bad scenarios and can help you sort of format answers to questions. As I said before, the interviews are all online and it's 20 minutes, so only 10 minutes per station, and it's the same panel for both sections, so you don't go back into a waiting room on, Teams and then back into a different station. It just carries on through with the same people. So 10 minutes of your interview will be the clinical stations, and this is 2 scenarios, each lasting 5 minutes. The scenario here on the screen is a typical scenario that you might be asked in the interview. It's usually that you're on call and that you've been asked to review either a post-op patient or a patient that you are about to go and see in A&E. On the whole, I think they usually try and do one patient that's like an ATLS scenario or an A&E assessment, and then one post-op surgical patient in line with the CRISP, which is one of the surgical courses that you'll need to go on, and it's a protocol about managing patients on the ward who are post-surgical. The main thing for this section of the interview is just get your ABCDE or your CABCDE absolutely nailed. It should just roll off the tongue, easy peasy, almost like a pre-prepared speech, and just tailor it obviously according to the scenario in front of you. For my interview, once they said the scenario, I took a moment to think about what I was going to say, and then I did an opening statement which basically just said, this is a sick patient or this is a trauma patient, and I would manage them as per the ATLS or the CRISP principles with nurse support or plus or minus a trauma call. By giving this opening statement, it sort of shows that you're confident in managing this patient, that you know what principles you're going to apply when assessing the patient, and it also gives you a moment to think about what you're going to say next. It also means that you don't forget to say things like, I would bring the member of nursing staff who's looking after the patient with me, and I'd also put out a trauma call, which often is forgotten if you're doing an ATLS type scenario. I then just spieled my ABCDE, and they just listen for everything. In my personal opinion, they won't interrupt you because they want to hear that you are going through the motions of an ATE assessment. You might hear that other interviewees were interrupted in their assessment, but they just let me do my whole assessment and then they asked me questions at the end. At the end of my A to E sort of spiel, I then sort of made an ending statement, and I said, I'd escalate it to whoever I needed to escalate it to. I'd review the notes, the drug chart, call the registrar or the consultant, inform theatre teams or the trauma team, etc. This sort of makes sure that the story that you have told sort of comes to an end, and it allows them then to know that you've finished and ask the relevant questions. Just a note to add, I have mentioned the ATLS and CRISP courses. You don't need to have done these courses before doing the interview at all. I have done ATLS, but I have not done the CRISP, which is the CRRISP course. All of the information for both of these are online. I would just recommend having a quick read. It just sort of goes through the A to E assessment of patients in a more specific trauma-related scenario and for patients who are unwell post-operation on the ward. So the other 10 minutes are the portfolio and the management station. This starts with a 3-minute presentation about leadership and 2-minute questioning from the panel about your presentation. This presentation title is given to you a couple of weeks before the interview, and it's usually themed about leadership. You need to give this presentation with no slides and no notes, so off memory, and it's only 3 minutes, which I think I figured out you can only say about 340 words. As you get the title of this presentation a couple of weeks before, there is no reason why you shouldn't get 100% marks in this section. You have plenty of time to practice and get this nailed and look like a really confident and clear presenter. I wrote my presentation down and then got advice from my friend who had been through the core surgical training route about whether she thought that this was the type of thing that I should be saying. You could also get advice from your registrars or consultants on what they think. And then I honed in to make sure that it fit in within the time. There are obviously lots of different formats you can use, but I used sort of an opening sentence saying how passionate and great I am, basically, and then saying 2 to 3 examples of myself being a leader in different scenarios. I picked one clinical scenario and one clinical scenario just to give 2 sides of the coin and to show that I have sort of a life outside of medicine and that I am a well-rounded human. It's important to relate each example back to being a core surgical trainee and how this will help you be a great candidate and a great core surgical trainee to work alongside. And then at the end, I did a closing statement, again, why I'd be a great leader within core surgical training. I have to say, it doesn't come naturally, sort of boasting about yourself, but it's really important that you basically say how great you are to make sure that the interviewers know that you are the candidate they should pick for the core surgical training place. After the presentation, they then either ask you questions specifically relating to your presentation or general sort of teamwork and leadership style questions, which the 2 books I mentioned before are really useful. They give examples and sort of example answers for the classic questions within this theme. After the presentation's out of the way, you can forget all about it and you're then onto the management scenario, which is a bit like the situational judgment test. As you can see, there's an example on the screen now, which is a very classic example about your senior smelling of alcohol and what do you do. Your revision for the MSRA SJT should come in really handy. Reading the GMC guidance and ethical guidance and things should really help you in this interview section. In the books I mentioned, they sort of suggest some acronyms and formats for answering management type questions, and I used these just to sort of format my answer and make sure that you don't miss anything. A useful piece of advice I got from a colleague is in any management scenario, offer at least one person a cup of tea, whether that's the patient, whether that's a colleague of yours or the person that smells of alcohol and that you need to get a taxi home for. Always offer someone a cup of tea and it makes you seem like a very normal human being, and most people would offer someone a cup of tea in a stressful scenario. So your interview panel is usually 2 assessors and 1 layperson to make sure that everything's running smoothly and as it should. There are different sections in which they mark in, and you can go online and see the sections, and they mark from 1 to 6. At the bottom of this slide, you can see that I've written that 1/4 of your total global score for your interview is communication. This score is purely based on how well you communicate, not only in your presentation, but also how you answer the questions. So you can get 25% of your marks, not really knowing anything, just having a good structure, answering slowly and clearly. If you need a question asked again, you can just say it's much better to ask a question again than to sort of get lost in wondering and rambling. Hopefully your sort of enthusiasm for surgery will come through, and then you're 25% of the way there. As I said previously, I didn't do a course and I even didn't practice that much with any consultants or registrars. I just read the books and I wrote an answer for almost every question example that they had in there. Examples of teamwork, leadership, managing difficult scenarios or colleagues, examples of when I've made a mistake and what I've learned from it. And I also learned 3 buzzwords for each headings, and both interview books have lists of buzzwords. I also read the person's specification, and there's a leadership document done by the Royal College of Surgeons that was really good to read as well. I basically spoke out answers to some of the questions in the shower, in my car, to my housemate, to my dog, every single day for a couple of weeks. I also practiced my speech like 3 times a day, and near the interview time I also did it into my computer camera And I actually did a Teams meeting with my mum and did the speech online to her, just so you can get used to the interface of presenting online. I also applied for radiology and anaesthetics, and these interviews are usually before core surgical training, so this was really good practice as well. So we're coming to the end of the presentation. I'm sorry that there's quite a lot of detail, but these are all the things that I really wish that I had known before I applied, which would have made everything sort of a bit easier and less stressful. So these are sort of some topics that you can start thinking about. So commitment to specialties. So if you're not sure you want to do surgery, attend some career days, speak to surgeons, do some taster days, look up the core surgical curriculum, because this is ultimately what you'll be studying and doing for 2 years and then beyond if you start applying for ST3. Read articles about research coming in surgery or any teaching that's going on at the medical school, and see if this sort of thing interests you and something that you would like to study in the future. And I would highly recommend start booking conferences now, going to one every few months, and then by the time you apply, you'll have 3 conferences really easily. So under the audit and research section, if you've done an audit or a QI project, even in the last 2 years, go back and collect the data again. It's so much easier to collect a second round of data on something that you've already started than starting from scratch. And then ask a consultant if you can present it to the next clinical governance meeting or an M&M meeting, or if you could present it at your GP surgery, wherever you are, to at least get 1 point for that presentation section. Enter any research, any abstract, any posters you've done in the past with updated data to all conferences you can possibly find. And this should hopefully help you get maximum points nearer the time of your application. Teaching-wise, it might be a bit too late to start doing a master's or a postgraduate certificate, but get on the Teach the Trainers course if you can and get that certificate, because that gets you 2 points. Also, don't stress too much about creating a teaching program. I gave examples before of how easily it's done to do a local program, which only drops 2 points from maximum points, so it's a really good place to start. There are lots of regional programs as well that have already been set up, and if you then take over a main leadership role within that and make some changes to the curriculum, you can then say that you have designed and led this program. And on to the last section, which is qualifications and experience. Again, start thinking about taster days if you're not sure about surgery. You can start thinking about doing your MRCS if you would like a little bit more time to do it and you're definitely sure that you want to do surgery. You can do courses as well, because during your CST years, you'll need to do a few courses, so you can think about doing those early. And if you're not sure or you need a bit more time, do an F3 year and get a surgical related fellow job. After COVID, I really just didn't think that I wanted to go straight into training, so I got a job as a clinical fellow in breast surgery, and it's been the best year ever. It's not only helped me really a lot with getting the amount of points that I got for my portfolio, it's also been a really nice year of 9 till 5 and actually having a really good work-life balance, which I think is really important before you embark on a difficult training program such as core surgery. Some other points that I really wish I had known earlier was how much detail the evidence upload would be. If you're in a position to start getting consultants to sign things or make a spreadsheet, write down what you need to submit and make sure that you've got consultant names, dates, and GMC numbers on everything. If you've done your surgical rotation recently, get that letter written and the consultant to sign it. Don't rely on consultants writing letters. I drafted each letter saying that I had done a surgical taster or a surgical placement, that I had been to conferences, and just got them to read over it, printed it in front of them, and just got them to sign it. By looking at the self-assessment criteria early, you can then ensure that the things that you're doing can get you points at the end. For example, I had done lots of ad hoc teaching and lots of serious teaching in the medical school, but this was not going to get me the maximum points. You needed to have designed and organised a teaching programme, plus gained feedback. If I had known this earlier, it would have been a lot less stress because I had more time to do this and more time to get the evidence. Personally, it gave me great relief to see that the publications section had been changed and that you can get into doing oral presentations and prizes, and that would get you the same number of points as publications. If you're still doing publications, great, continue that because that will get you points down the line. But don't stress about getting them in time for your core surgery application. Get into conferences and get presenting. I really only 100% decided that I wanted to apply for surgery last summer, so about 5 months before applications opened. I was always toying with the idea, but I really wasn't sure that I would get in. But I'd kept my portfolio up to date and said yes to any opportunity that had arisen. So by the time I came around to applying, I had enough experience on teaching and conferences, etc. If I can gather everything you need for the self-assessment upload, revise for the MSRA, and do the interview, all sort of about within an 8-month period, you can definitely do it as well. Thanks so much for listening to this talk. I hope you found it helpful. My contact details are on the first slide, so if you have any further questions, you can contact me via email. For other talks in the Heads Up series, you can go to Make a Medic on YouTube, Instagram, and Facebook. And like, follow, and subscribe for much more content.